Hi, I'm Yolanda and this is Speak On. Welcome to Speak On Presents We Need to Talk About Mental Health. In this session, we're going to be talking to Dr. Yvette, and she is awesome. And we're going to be talking about mental health stigma and misconceptions and disorders that are like commonly misunderstood. And commonly misunderstood sometimes because of the way they're portrayed in TV, film, in popular culture, etc. So I'm going to hand over to Yvette initially, and then we're going to have a chat through those things. And then later on, we're going to have Ian and Lucy that are going to join us for a Q&A and to talk about their own experiences with mental health. And hi, Vanessa, by the way. Okay, all right, over to you, Yvette.
Thank you. So hello everyone. So I am Dr. Yvette Arthur and I am a clinical psychologist. I currently work in an early intervention service for people experiencing a first episode of psychosis, and I'm sure we're going to touch on what is psychosis in a bit. But I do one-to-one therapy, group therapy, family therapy. I do consultations with my team as well. I do research. So as a clinical psychologist, I have both the therapy hat and the research hat. And then I also do consultation for children's home as well, which is local to me. But I'm really, really passionate about mental health and advocating for mental health and encouraging people to seek help. So I'm really grateful to Yolanda and the team at Speak On Series for inviting me to talk about misconceptions, stigma, clarifying everything I hope for you today so that it just feels less overwhelming when we think about and talk about mental health. So thank you again, Yolanda. So just a bit of a warning, highlight about today. We're going to talk about things that are really sensitive. Mental health is serious, it's not a joke, but the hope of the session is to give you helpful information about mental health difficulties and increase awareness of how to get help. We want you to know that you're not alone if you're struggling right now with how you're feeling and maybe thoughts that are really negative. You are not alone, but we know that some of our audience who are here today might find the content distressing and it might trigger some worries. And we apologize for this in advance, and that's not our aim. But we want you to get help as soon as possible. As this is a weird kind of virtual space that we're in, we can't see you and come up to you at the end of the event, but I'm going to give some contact details to Yolanda and the team at Speak On so that she can send it round in terms of contacting helplines that you can call at any time, like the Samaritans, and other places to get help, like your GP, therapy services, apps as well. I've got that listed, so I'm going to send that to Yolanda so that she can share that. But if you can just begin to think of something that you'll do nice after today's session, that would be really, really helpful. It could be talking to a friend, doing some exercise if you're that way inclined. I think I'm more the stay-at-home type. But make a note of something that you can do that will be really nice to take care of yourself, because you've done really well to even attend today's session. So hopefully that helps. And I will hand back to Yolanda.
Brilliant. Thank you so much. Okay, so first of all, just to kind of give some context about why this is a subject that was chosen as part of this, we need to talk about mental health. I work in media and so in social media and like TV, film, etc. And I know that there is a lot of incorrect usage of some of these words. And my sister is a clinical psychologist and is constantly correcting these things and getting frustrated by it as well. So I have basically listed a few of the there's many, but a few disorders that we can go through so we can with a little bit of clarification and hopefully kind of clear up some stigmas around it. And you can all leave like more educated as well, which is always good. Okay, so first question. Can you break down the misconceptions of like mental health as a whole? Because like, you know, there's some people like, oh, I'm perfectly fine. But then others will say, well, everybody has some degree of mental health issue or disorder.
Yeah. So it's all really based on the terminology. So we all have mental health in the same way that we all have physical health. So mental health is literally your ability to contribute to society and people around you, to fulfill your potential in life, and to connect with family and friends. And now, so we think of mental illness, or mental health difficulties, which is a word I prefer more than illness. That's anything that affects your ability to do those types of things. So that might be that you want to socialize with your friends, but actually you feel really anxious when you're in quite busy and sociable places like a restaurant. So then we will think about what is getting in the way of that. And sometimes we might use a diagnosis to describe that as a way of communicating that efficiently. But really and truly, we're thinking about what is your specific difficulties about meeting with your friends, because that's part of our mental health. And why I say it's like physical health, it normalizes mental health if we compare it to physical health. There's something called parity of esteem, which feels like a really big word, but it's just an encouragement that we shouldn't see mental health as something that is stigmatized, that it's the person's fault, but very much that it should be akin to physical health. In the same way that if I was in the hospital with a broken leg, I know I'll get people to visit. It's the same way in which we should treat people who are experiencing difficulties to their mental health, and difficulties in understanding how mental health develops as well, which I'm sure we'll get onto.
Okay, so we need to nourish it basically like our physical health. We need to kind of take care of it and look after it. How can we do that more?
That's a really, really good question. And I think at the most basic level, it starts with something that I use my Instagram to talk loads about, is self-care. Mm-hmm. And the reason why we promote self-care so much is it's literally like a barrier that when your stress level, if we think about mental illness or mental health difficulties being up here and good mental health being down here, when the stress level is kind of filling up, self-care can be that kind of in-between barrier to bring it down again and literally release the taps that are building up that pressure. And self-care can look like many different things. It's not always a bubble bath. Because to me that wouldn't be self-care. I'll be stressed because I have kids and they'll be banging on the door. But self-care is just a way for you to reconnect with your values, the things that are important to you, to have a laugh, to de-stress, to feel as though that you are supported and that you can support others. So mental health, self-care can look differently to different people, but that would be the first line of action, I would say, which is really important. And then also taking time out to acknowledge how your day has been, how you've been thinking and how you've been feeling. And I think that's something that stood up to me during this lockdown, is that our busyness didn't allow us to kind of reflect until we were kind of forced to, because everyone was staying at home. So we had more time to think about actually, like, what do I like doing? The reason why we're shouting at that person who jumped the queue in Tesco, who is really annoying, is not just about that person, but sometimes we're dealing with stress at work and then we're carrying that. And the tip of the iceberg is the fact that someone pushed in front of you. But if we develop that self-awareness of how we're thinking and feeling and getting in touch with ourselves, then we can acknowledge that and then troubleshoot around that. If it's something at work, then we can think, okay, do I need to speak to my manager or speak to my HR team? We can problem solve instead of carrying that as well. And I think it's really important that we learn to share as a community, as a body of people, because that's really important for managing our mental health, that we're able to de-stress and share things and share our vulnerabilities and not feel as though we're weak or oversensitive, which is a word that I hate, for doing so. But actually we're human beings and we're bound to be affected by things that kind of touch on our emotions and so forth. So normalizing those type of conversations is really important for managing our mental health.
Brilliant, thank you. So now we're going to talk about some misconceptions. I have a really long list, so we'll touch on some of them. But I think let's start with misconceptions, and also I suppose, and you can explain, go a little bit further and tell us what it actually is. OCD. So we hear this a lot. We hear it from the Kardashians. We hear it from people we're just walking in the street. Oh, I'm so OCD. Or as Khloe Kardashian calls it, Clo-CD, just because she likes a really neat shelf. What is it? And what other kind of misconceptions are there about it?
Yes. So I guess the biggest misconception is that you can be a little bit OCD because you like things in order. You like your the tins on your baked beans to be all facing in the front. And that to me is more about perfectionism and maybe just something that you like and you prefer. But OCD is actually a very serious mental health condition that affects people from all ages and all walks of life. And it's about getting caught up in a cycle of obsessions and compulsions. Now, obsessions are unwanted, intrusive thoughts, and we call them intrusive because they literally interfere with your life without you wanting it or bringing it on. And it can be thoughts, it can be images, it can be urges, but they're distressing in the way that they make you feel. So that's the number one. But also you need to have the compulsion, which is the other important bit. So these are behaviors which someone might engage in to get rid of the distress that the obsession causes, and with the aim to decrease that distress. And now why it becomes a mental health difficulty is that people get caught up in that cycle of, I've forgotten, have I locked the door? And then I need to check it. Okay, I need to check it a certain amount of times because I still feel anxious that I haven't checked it well. And some people might be there for hours. And you can imagine their friendships, their work life, how they feel about themselves. So it's that kind of cycle that we highlight when we think about OCD, the obsessions and the compulsions. And again, it's just people thinking you can be a bit obsessed about something, but is it really causing you distress to the point where you can't engage with the things that are important to you? And I think saying you're perfectionist is okay as well, and maybe that should be normalized a bit. Actually, I like things like this, and that's okay too.
Yes, I think people often talk about, like, there's something wrong with wanting to be neat and tidy, and then that's where they kind of bridge that gap between, I suppose, that misunderstanding of what OCD is and them just liking a neat shelf. Oh, we're frozen a bit. Oh, lost her. Okay, back in 1 sec. We'll get back in a minute. Oh, brilliant.
I'm so sorry. It completely cut out. I don't know what happened.
That's all right, no worries.
I'm sorry. Sorry, everyone, as well.
Okay, so yes, so the kind of, like you were saying about normalizing saying you're a perfectionist. So kind of, I suppose people then bridge the gap between thinking I'm a perfectionist and this doesn't feel normal to me, that I want things this neat, and they're bringing it all the way over to what OCD is because they don't really understand what that means.
Yeah, literally, because you can be a perfectionist that you want all your tins to be in one order and with all the labels at the front, and that's a bit of an obsession. But you might not have the distress that means that if it's not in that way, you feel as though something bad might happen, or you get worried about something and then have the compulsion and have to keep doing that. I think it's that repetitive cycle that we kind of look for.
And how is it diagnosed?
Yeah, so OCD or any kind of mental health disorder is diagnosed through an assessment. So usually that is with a psychologist or a psychiatrist, and that involves us thinking about various things. So it's thinking about what difficulties that you're experiencing right now, what triggered those difficulties, because that's really important. If you feel like you've been a bit OCD-ish for the whole of your life, that is very different to actually you had a major event in which maybe someone broke into your home and then that kind of triggered the OCD. We then think about what keeps the problems going as well, what perpetuates it. We might think about things that made you vulnerable to have mental health difficulties in the beginning. So that might be thinking about genetics, whether you're a close family member struggled with mental health difficulties. And then we also think about protective factors, so things that you are doing that kind of help you to function well. So it's through like a talking assessment. As a psychologist, we also have questionnaires that we used. Sometimes it's not as if you can read the questionnaire and then you can diagnose. You need to do that as well as considering the person's history. So it's like a long process, I would say. And I like to be quite thorough, because I think giving someone a diagnosis is quite serious.
Yeah.
So I would always hesitate with just saying, oh, you're a bit obsessive, or you're a bit OCD-ish, because it's quite a serious diagnosis.
Yeah. I think a lot of people don't realize what it is. I have a friend, she has OCD, and she is like an ambassador for an OCD charity. And she broke the handle off her door by checking it, you know, and then people don't realize that's kind of the extreme levels. Or even, she doesn't live that far away from me, but to get to my house, it could take her 15 minutes, or it could take her 2 hours. And so, because she has to go through these kind of these patterns of behavior, and she has to go back and check her house, etc. And takes a lot for her to come to mind, takes a lot, like mentally, that takes a lot of kind of talking to us. And I think people don't necessarily realize that how serious that can be.
Exactly. And thereby impacting on her friendships, how she contributes to the world and to others, and how she makes use of her full potential. You can see that affecting all those areas, instead of it just being like 5 minutes.
Yeah.
You know, it's the severity that I think that people miss in the way that it's talked about on social media.
Yeah.
And with the Kardashians, you're not getting that severity.
No. So actually, talking about the Kardashians, let's go over to something else they commonly use, and I feel like it's become common parlance now, because not because of them, I'm not blaming everything that's bad happening on them, but I know it's common parlance now that people will say, I have anxiety. And so I'm not dismissing anyone feeling anxious, but I know that there are, in terms of, they say, oh, looking at that terrible top gives me anxiety. So it's become kind of a throwaway comment as well. But what is anxiety? Because I feel like this is something that is quite misunderstood.
Yes, yeah. And so I guess it's helpful to understand then that when we think about mental health, we think about it as being on a continuum. So obviously mental health is you're looking after yourself, as I've been saying, those 3 areas: contributing friends, family, contributing to the world around you, and making the use of your potential. Then on the other side of that continuum would be anything that kind of affects that to the severe point. So anxiety, we would look for very, very severe, that affects all areas of your life. And sometimes it's helpful to think of it as a continuum, because then that reduces stigma. It means that someone doesn't fall into mental health difficulties and then fall out of it. Actually, it's a life. It might be something that they manage over their life, or something that they just need to manage for that time being.
Yeah.
But I think that also leads to people saying, oh, I've just got a bit of anxiety, and that means I'm an anxious person. But when we think about anxiety, there's quite a number of diagnosis actually under anxiety. So thinking about generalized anxiety disorder, that means having uncontrollable worry and anxiety about different things in life, and feeling as though you can't tolerate uncertainty as well as a big thing. And then we have social anxiety, and I think everyone might be a bit more familiar with that, and that is an extreme fear or anxiety that's triggered by social situations like parties and workplaces. That's also known as social phobia. And then we have panic disorder, which also comes under anxiety. So that's frequent panic attacks without a clear trigger and feeling as though you're going to die. Yeah. And then we have general phobias as well. Around spiders is really, really common, or heights as well. And then we have post-traumatic stress disorder, and that comes under anxiety as well. And that's obviously after you've experienced a traumatic life event, and you feel as though it keeps happening again, and your brain is doing everything to keep yourself safe. And OCD actually comes under anxiety. You also have health anxiety as well, and that might be obsessions and compulsions related to illness as well. And body dysmorphic disorder, that means obsessions and compulsions related to your physical appearance. So I guess the concern about using the term anxiety, is that you kind of lose actually what is the person experiencing. And hopefully that's highlighted that there's many different forms of what we know by anxiety, or what we call anxiety. And it's important that we take an individual kind of understanding around it.
Yeah, brilliant. Thank you so much for that. That's really cleared up a lot, because I had some more questions, but you've actually answered them all in there. Like,
have I?
That's brilliant. It's perfect. Okay, so thinking of other ones. So basically, to let the audience know, when we were pulling everything together, we were asking people like, what disorders do you want to know about? What what things do you like misunderstand, and looking at portrayal in films and TV. And so another one that came up was bipolar disorder, because this is something that has been portrayed in TV and film loads. There was actually a show that was on in America called Black Box, which is about a doctor that had bipolar disorder, and it was, you know, kind of showed the extremes of what that means. So if you can just explain what bipolar disorder is and the misconceptions around it, that'd be great.
Yes, yeah. So bipolar disorder, and that's something that I sometimes, a presentation that I might support people with in my service. So bipolar is also known as affective disorder. So that highlights there's a mood element to it, but it's literally that your mood kind of swings from extreme highs to extreme lows. In the high part, which is also known as manic and mania. And I think people can use that term and say, oh, I'm a bit manic today because I've got lots of energy. Actually, it's a bit more serious than that. It's increased energy, excitement, impulsive behavior, and agitation. So it's having all of those kind of feelings combined. And then on the other side of it, then we have depression, which is a lack of energy, feeling worthless, low self-esteem, and suicidal thoughts. People may also experience psychotic symptoms. So that's why I might support people within my team as well. And again, that's seeing things that other people don't see and hearing things that other people don't hear. And so there's like various different types of bipolar disorder. There's bipolar 1, which means that you have a certain number of weeks in the period of mania. And then you have a certain number of weeks in the period of depression. And then you have bipolar 2, which means that you have more common symptoms of depression rather than mania. So hopefully that's getting to understand that it's a bit more severe and longer term than I turn a bit manic on Saturdays and I get happy on Saturdays. And I think that might be the biggest misconception. If your mood swings, actually, that might be because something triggered it. With bipolar, it's sometimes tricky to understand what the triggers are. And that's why people need support around it, accessing therapy or sometimes medication as well. But it's highlighting that it's severe. It's a long-term kind of change in mood that sometimes it's even difficult to reconcile where you are in between that. In between the high, extreme high, and then the extreme low.
And is it something that's easy to stabilize? Or say not so easy, but is it something that can be stabilized and then you could live a very long time without having an episode, or is it something that's cyclical?
You know, everyone is really different, and I think it's important to be open to the fact that some people might be on medication for a longer period of time and some people might not. But in terms of how we support people experiencing bipolar, it's usually medication, because the research has shown that there's a chemicals in your brain element to it, as well as talking therapy, which would help you find the kind of medium between the high extremes and the low extremes. So it's a combination of both. Some people find that the strategies that they learn from therapy has allowed them to kind of fulfill their potential in life and be part of their community without taking medication. And for other people, they might rely a bit more on medication, but it can vary a lot. But it's one of those kind of mental health difficulties where both medication and therapy are recommended.
Okay, brilliant, thank you. So I'm going to just going through my list here. So something I feel that I think sometimes people may get mixed up is bipolar disorder and borderline personality disorder. So what are the differences between these two?
So the biggest difference with bipolar disorder is that the person may experience difficulties with knowing who they are, and reconciling the kind of extreme mood states that they experience between extreme high and sometimes feeling quite low. So then touches on similarities with bipolar disorder. But with borderline, it's difficult to know who you are in those kind of extreme mood states. Also with borderline personality disorder, we also see people experience a sense of emptiness in how they feel, and feeling as though their feelings are given to them by others. People may also experience a sense of abandonment and do anything possible to not feel that abandonment, even if it means something quite drastic, in terms of maybe saying something that is really, really drastic as well. with borderline personality disorder as well, people might experience what we call dissociative episodes. So that's episodes where they feel as though it's almost like a break from reality. So they feel as though they're outside of their body and they're watching themselves, or they're seeing themselves kind of at a distance, or they have difficulty remembering things. So those are some of the key differences that I found around bipolar disorder and borderline. And also bipolar disorder, we're looking for quite a long period of instability in mood, whereas with borderline it can be short-lived, those changes in mood. But sometimes, and this is where it's tricky, you can have both as well.
That's like dual diagnosis.
Dual diagnosis is slightly different. So dual diagnosis thinks about you having a mental health difficulty and an addiction to alcohol or drugs.
Okay.
So with both, in that way, it will be called a comorbidity. And then it's kind of referred to, maybe you have one which is affecting your life a bit more than the other as well. Yeah, so that's the difference between dual diagnosis and comorbidity. And one thing I've got to say is that with borderline personality, we also see difficulties with the way that people relate to others to a greater extent than bipolar as well. And borderline personality is also known as emotionally unstable personality disorder. So that highlights then again the difficulties with emotions too.
And so sorry, before I interrupt you about dual diagnosis, if people are have both, like what can happen in that case?
Yeah, so we commonly see, working in the psychosis service, so people who are smoking cannabis, which is really, really common, and experiencing symptoms or experiences around psychosis. So in my service, we would focus on the psychosis, and then we have other services that will focus on working around what the person might consider to be an addiction. So whether that's cannabis or whether that is alcohol. And again, it's thinking about the severity, whether that's having an effect on the psychosis. We might prioritize maybe seeking the drug detox more than the mental health side, with the psychosis a bit more. But usually people do access both services at the same time. Actually, it would be great to have it all integrated to one services, but that's something that I think the NHS is lagging behind a bit in.
And is it common for people to have more than one disorder? So for example, bipolar disorder and ADHD and anxiety and depression, is it possible to have all of these things at once?
It's really, really common and very much possible. Something that I see in my service a lot is when people might have psychosis and social anxiety, because that crosses over a lot, or psychosis and obsessive compulsive disorder as well. And then also the kind of neuroatypical difficulties, which is thinking about ADHD and autism, as well as a mental health difficulty. So that's really, really common to have that comorbidity. And it just highlights how complex mental health difficulties are. And although we're kind of led by diagnosis, because that's the way the services are set up, actually, when I'm working with someone, I might not be treating psychosis. It might be focusing on sleep. It might be focusing on low mood. It might be focusing on social anxiety at that moment. So it is, it's quite common for the two to occur.
Okay. So some of the other disorders on the list. The next one is schizophrenia. So now this is something that sometimes it's just kind of harking back how it links to misconceptions in media, where people will say they've gone psycho, they've gone schizo, or they use kind of those kind of terms in films, TV, etc. So what exactly is schizophrenia?
Yes, so again, it's a really, really serious mental health condition. It's one of those that we consider to be severe and enduring. So it's more focused on the way that people think. It's slightly rare than depression and anxiety, which is like 1 in 3. Schizophrenia is about 1 to 2 in every 100 people. So you can have positive and negative symptoms of schizophrenia. So the positive symptoms are hallucinations. So that is literally hearing voices, seeing things, smelling things that other people don't smell, feeling touches and sensations that other people don't sense, or even taste as well that other people are not tasting at the same time. And also delusion, so that is believing something that is untrue. There's also the negative symptoms, which is a big thing about schizophrenia, because then you know why it's kind of a longer term difficulty. So that is a lack of motivation and being withdrawn. And it can last longer than the positive symptoms. But schizophrenia is caused by genetics and the environment, and we kind of take a biological, psychological and social approach to understanding schizophrenia. Now, how it touches on psychosis, because in my service I hear people say a lot, if I have psychosis, does it mean I have schizophrenia? And at that point it's too early to tell. Schizophrenia is more the chronic difficulty than a kind of short-lived episode, which might be about maybe 2 years, which is how our service is funded. So some people might experience a psychotic episode once, and then they feel much better afterwards through help and support. Whereas with schizophrenia, it's the longer term difficulty of telling what is real and what is not real, and that break from reality.
Okay, and then at what age do people develop schizophrenia? Can it happen at any age, or is it really specific?
So it's usually that we see people in early adulthood. So that kind of 18, 19, 20, and then into the early 20s. That's where we see schizophrenia predominantly develop. But we've also seen people kind of develop schizophrenia later on in life as well. Yeah. But that's quite rare. It's more the late teens to the early adulthood that people develop.
Yeah. And also that with psychosis, what can trigger psychosis? Because I'm guessing that can that just happen out of the blue, or is there like a build up to it? How does that occur?
So it varies so much. So on one side, there can be a build up of stress. So when I'm kind of talking to my clients about it in the service, we think of understandings around psychosis as being a bucket. So we all have our buckets, and the size of our buckets depends on our genetic vulnerability to developing mental health difficulties. Now, if you have a first degree relative, like a parent or a sibling who has psychosis, then maybe your bucket might be a bit smaller. And if you don't, your bucket is a bit bigger. And then what fills up your bucket then is the daily stresses, bullying, experiences of racism or being discriminated against, fills up over time. And if we kind of use unhelpful coping strategies, we continue to fill up our bucket without kind of letting that being released and that water to come down, or we kind of block those taps that might reduce the water and the stress. And that might be using drugs or alcohol or avoiding others as a way of coping with it. But instead, we encourage people to kind of open their taps and release the water and use more helpful coping strategies. So psychosis, we think of in one way as being a combination of stress and vulnerability. However, we also know that people can experience psychosis after a brain injury. Okay. After, we've seen it a lot in our older adults, after syphilis as well, like a serious kind of infection can lead to delirium, which can also look like psychosis, and also drug induced. So there's a certain kind of ingredient in some of the cannabis called THC. I'll probably get the full name, but I probably won't be able to pronounce it. But it's known as a better acronym as THC. So when there's a high level of that in cannabis, it can kind of trigger a psychotic episode in someone who might have been experiencing stress and so forth. So that might also look like skunk as well, because that has a higher level. But the difficulty is you can't tell what's in it. But that is when we think of it as being kind of out of the blue a bit more than the other stress, vulnerability, or having a head injury and so forth.
Okay, brilliant. And well, I think at this point it'd be really great to I'm going to bring in Ian and Lucy, so we can go through the rest of our questions, but then also talk about their lived experiences as well. So I'm just going to... Bear with me a sec.
Hi.
Hello.
Hello, everybody.
Welcome. Okay, so we've gone through, went through with Yvette over some of the different disorders and what people, I suppose, like, I mean, everything that you said of it, I didn't know. I'd say I didn't know about 75% of that. And anything I knew was either through secondhand or assumptions or watching TV, which is not great, which is why we need to have these kind of conversations. So I'm going to start off with Yvette with this one and then go to everyone else as well. But how can we break down the stigmas around any of these disorders?
Yeah, I think that's a really, really good question. The first thing for me would be to acknowledge that having a mental health difficulty is not the person's fault. Because to me, that's one of the biggest stigmas that lead to people not seeking help because they think that they've done something wrong or they're not strong enough, they're weak in character. And that's completely not true at all. Actually, you've probably been doing your utmost best to kind of cope with what you've been experiencing, but it's just become too much. And in the same way that if we have a pain in our leg, we're not going to sit down at home and say, oh, I'm just going to overcome it and not go to my GP. We're going to seek help. So the thing is, acknowledging that there's multiple factors that contribute to mental health difficulty that are very complex and varied and individual that we need to understand. I think people accessing reliable information is really important. I think it might also be a generational thing. So it's also about maybe the older generation getting used to talking about mental health and the younger generation being able to link in with that conversation and share things as well. I think also a big thing is how you access mental health services and maybe reducing the stigma around that. So I'm very keen of not calling I call the people that I work with clients rather than patients, because it can very much feel as though you're helpless, where very much for you to even access mental health support, actually you're really strong to come out and say that you're experiencing this. So those are some of my brief thoughts on challenging stigma.
Thank you. I'm going to go to Ian. Why is it so important to break down these stigmas, and how does it feel to be on the receiving end of when people really don't understand?
I guess the importance of it is so that everybody can feel human. Mm-hmm. You know, because you know, the most important thing is to be validated, isn't it, in some shape or form, regardless of who you are. I think the most memorable experience I've had of experiencing a stigma and it impacting on me. I mean, I guess self-stigma is worse than anybody stigmatizing you. But I don't know if you guys remember the Germanwings plane crash. And I happened to be in Preston at the time. I was up there for visiting the University of Central Lancashire. And so, you know, what brought it home to me was I was hearing on the news about this plane crash. And as soon as the media ruled out terrorism, the next thing they leapt onto, well, it must have been a mental health issue. So there's a natural assumption that people leap to that we all need an explanation of something that happens, an event, a life event, particularly if it's something that's dramatic and impacts on a large population, you know. And so you end up with this kind of leap into a conclusion that if it's not this, therefore it must be that. Yeah. So I want to see, you know, an end to that kind of leap into conclusions. Mm-hmm. You know, I am very much an individual and I prefer to be treated that way, as I'm sure the rest of you do.
Yeah, brilliant, thank you. And over to Lucy. Why do you think, like for you, actually I'm going to ask you the same question, why is it important for you to break down those stigmas, and how does it feel to be on the receiving end of when people don't understand at all? And also, actually, just to tell the audience, so Lucy has BPD and Ian has had psychosis, so he had I don't know how to say that properly. What's the correct way to say that? Sorry, Ian.
Psychotic episode.
There we go, had a psychotic episode. So we're going to go into that a little bit more in a minute. See, I'm still learning. I'm learning as we're going. So Lucy, if I go to you and ask that same thing, why is it important that we break down stigmas?
I suppose to basically mirror what Ian said, what everybody wants is to feel human and to feel understood, but also to understand yourself when you're going through something as complex as either a psychotic episode or struggling with something that is more enduring long term. A lot of the time, and me personally, because I have BPD, I feel very often like I'm some kind of freak, because the whole world doesn't really make sense to me. My brain doesn't work the same way that a neurotypical person's does. And that means that the whole world can be very scary a lot of the time. Normal adult situations seem very confronting and too much to deal with a lot of the time. So even listening to Dr. Yvette just speak about kind of just like the diagnostic criteria for BPD makes me sit there and go, yep, that's me, because it makes you feel like you're not alone. There's other people, there's a whole group of people that have the same illness as I do, that feel exactly the same way that I do. They can feel helpless, they can feel abandoned, they can feel angry at things that wouldn't make other people angry. There is still so much stigma around all mental illness, particularly things like addiction. People just assuming if someone, particularly if it's a drug addict, people just assume that they've done something, they've screwed up their own life, when actually you're speaking about an illness. Exactly the same with alcoholism or any kind of addiction. It's very often just a trauma response. You've gone through something that was too difficult for you to deal with, and you use something else as a coping mechanism. And that was certainly what happened to me with my eating disorder. I think that my struggles with bulimia and anorexia really came about because I had borderline and hadn't had the diagnosis, so therefore didn't have any access to any of the help that could have helped me deal with it in a healthier way, rather than me, engaging in disordered eating behaviors. That was my coping mechanism. And then the stigmas that go along with that, again, just reinforce the illness, reinforce that loneliness and that feeling of helplessness. So I think speaking about things and being as honest as possible is always the way to kind of begin to break down those kind of stigmas.
Yeah. Brilliant, thank you. And actually, so going over to Ian, so you had a psychotic episode. Can you tell us about that? Like, kind of give us it in microcosm.
I mean, it's difficult to do that because it's like, we've said that kind of everything is as a build up. Mine, I guess, started in being bullied in school, and then as Yvette says that there's genetic factors. So there's a history of certain things in the household. And then you've got all these constructed bits that kind of add together, and then there's lots of pressures in my life, a stressful job, financial pressures, difficulties in parents, and their response to me, all of that kind of stuff that's going on, but primarily I feel rooted in bullying. And then as things build up, and I kind of described it as being like a bucket, whereas I see it as being a bit like a volcano, or a pressure cooker, where you kind of get to a certain point and then everything pops. And so it got to the point where, it popped. And then, things go to a little bit of an extreme. And so I came up with a solution to the global financial crisis. That's what I came up with. And then it became something from that point onwards. And my thoughts had kind of taken over and comes to it, in essence, kind of a bit unreal. And then it builds and builds and builds and builds, and it's continuing to go. I describe it as a bit like a Big Bang Theory, but with your thinking. So it starts off with a seed of a thought and then expands, and then it continues to get bigger and bigger and bigger until it takes over your whole existence. So when I've arrived in hospital, I'm already at the stage where I'm kind of almost living in an alternative existence. And then I'm starting to be able to do things that you probably wouldn't ordinarily be able to do, like make myself disappear from my hospital bed, like in like a Star Trek movie, right, and reappear in the corridor outside because I've got some guy sat there having me on suicide watch, right? And so I can take myself from my bed, reappear in the corridor and have a look up and down and check out if there's anybody moving around or whether I'm all right. And then one day when I kind of made myself appear in the corridor, there's a queue of samurai warriors waiting to come in and set me some challenges. And, you know, as a family, we used to do martial arts together, you know, so it kind of all adds up. Right. And then, you know, I'm, you know, being set tasked by these samurai warriors. But, you know, if I kind of describe like being in that state, it's like being in a live dream state.
Yeah.
This is real. It's not imaginary. You know, it's very much happening. Right. And so, you know, I always kind of thought to myself, I wouldn't, you know, somebody said to me, I've been abducted by aliens. I thought, yeah, what load of old tosh. But I believe them wholeheartedly now, having had the experience that I've had. You know, so, you know, when the samurai came in to set me tasks, I'm the only one who can see them. The guy at the door can't see them. And they're coming in and I can hear the sword swish and I can feel it on my neck. Right. And then they're making me perform a task. So in order to not have my head cut off, I had to perform a task. So I kind of leave my bedroom, run into the main social area of the ward, and there's a telephone by the nurses' station I have to pick up and dial 999 and then put it down, and then I've completed that task.
Yeah.
Right? And you sort of the trouble is I'm doing it butt naked and soaking wet, because part of the routine that goes with it is I have to go into the shower, I have to look in the mirror, I have to come out of the room backwards, I have to fiddle about with the safe, I have to hurdle the guy who's in the door. You know, so there I am, quite a bulky bloke, dripping wet, hurdling this guy, right, and then legging it around the corridor and through the main doors and picking up this phone. And, you know, I managed to achieve that a couple of occasions. And on the third occasion, I got caught. And then, you know, it's not nice being restrained, and it's not nice being injected against your will. And then it's the most terrified I've ever been in my life, because you're laying there and you're kind of thinking to yourself, well, you know, you might as well kill me, because if you don't, that samurai's going to do it when you let me go. You know, and it's you know, it's a terrifying thing. And, you know, when we think about treatment, you know, I was put on haloperidol, which is like a, yeah, exactly. yeah.
I saw that face.
Yeah, so, yeah, and, you know, assisted with lorazepam, right? And, you know, it's a combination, and that kind of then winds you back in.
Yeah.
Right? And then what happens when it does wind you back in is you go through the level and drop to the floor, and so you go completely the other way, and then you end up in the depths of despair and depression. So I can remember my trip to the ward, but I can't remember when I got transferred back to my hometown.
Yeah.
You know, the journey there was quite memorable, because I was managing to control traffic with my mind and do all kind of wonderful things, you know. But you know, on the way back, I couldn't do any of that stuff. You know, I couldn't even remember the trip. So it's it's a very enlightening experience if you choose to view it in that way.
Yeah.
And I'm just lucky that I got to a point where I could say in a ward round that I didn't like the way the medication made me feel. So I got taken off haloperidol and put on a mood stabilizer. Right, but I think if I'd still remained on haloperidol, then I wouldn't be back at work. It's just, you know, work and it are not compatible.
Yeah.
You know, so it's not a thing you can really do when you're kind of that zoned out. It's,
so when you went through that, and then you're put on medication, etc. So how long did it take before you could go back to work, or how long did it take before you felt, I don't know, more closely to how you felt before any of that happened?
Okay. I was back to work within 6 months.
Yeah.
Right? But I would say I'm still returning to me now, because, you know, I don't think you're never going to be the same you after an event that you were before. You know, and you know, I guess, you know, diagnosis, you know, treatment gives you things to reflect on. So I'm kind of lucky that I was a social worker before this stuff happened. And I can use all those social work tools to reflect back on it and say, oh yeah, I can see how, you know, bipolar diagnosis means this, and how it impacted on my relationships, you know, relationships with children's mothers, all of that stuff, you know, where I could probably be an absolute nightmare to live with, right?
Yeah.
And then you look at it and you think, yeah, I can see how that would be the case, and therefore you look at it and you think, you know, I struggle with relationships largely because of a lot of that stuff, you know. And then you kind of, I like to reflect back on it. It's useful to do it, right? But it's also hurtful to yourself, because you sort of think, you know, I put people through a lot of pain, you know, that I didn't intend to do.
Yeah.
Was, right? And then you discover for yourself that unintentionally I would have been putting people through quite extreme pain at times.
Yeah. And then now, so who's your like, do you have like a main support system now after that? Is it the same support system you had before, or is that altered now?
No, I think my support system has shrunk, right? Because, you know, it's kind of, you know, the people that are really, really important to me are the people that are closest to me, the people I love and care for, you know. So my immediate family, you know, my extended family are kind of not so helpful, because they're more judging of me than my immediate family. My immediate family, you know, validate me constantly, and so it's not a problem, you know. In work, I was really, really lucky to have a couple of people who I can go to when I'm feeling not myself, and I can use them as an external locus of control.
Yeah.
So I can go and say, oh, you know, this has happened, I'm feeling like this. Yeah. What's your interpretation of it? And because I kind of trust them implicitly, they will tell me and I will believe them, and then it will re-center me.
Yeah.
And that works terrifically well, but you have to really, really, really trust those individuals.
Yeah.
You know, and you know, for me, I guess, you know, working in the job I do, and, you know, being around the people I am, you know, you instinctively know whether somebody has your best interests at heart.
Yeah.
You can't trick instinct. It doesn't matter how unwell you are. You know if somebody is caring for you. You know, I just think, you know, when it comes to, you know, receiving treatment, you know, my interactions with psychiatry have been interesting.
Yeah.
Because quite often it's been ticky box exercise where, you know, and at the beginning, you know, once I twigged that that's what it was, and I started playing with the psychiatrists, you know, because I'd think, well, you know, you're going to want to see if I'm manic or depressed, and so I'm going to then feed you some stuff, right? And then when I fed you some stuff, I'll see what you've written in the letter to my GP, you know. But, you know, eventually that bites you in the bum, because it kind of, you at the point when you actually need them, you know, you've kind of set a different picture, you know. And I guess, you know, I got to working with one psychiatrist who was more a psychosocial type approach, and that really, really worked quite well with me. But, you know, apart from that, it was a little bit too medicalised for my liking.
Yeah. And I suppose one of the main things I'm getting from your story is as well, and I'm sure like Yvette can expand on it too, is the importance of breaking down stigmas. If we all understood it more, the difference that would have made to your relationships and to how other people acted around you. So Yvette, is it quite common to see people's kind of social circles and support systems shrink during this time?
Yes, it is common, because I think it stems from old beliefs that if you're around someone who's experiencing a severe mental difficulty, you're going to somehow catch it, which is completely untrue. Or the person might be violent towards you, and that's completely untrue as well. They're responding to what they're experiencing, which if you take time to be curious about it, it makes sense. As to why they might be running in that way or so forth, if they feel like something is chasing them. And I think that, it leads to the circle getting smaller, and also people are unsure of what to say. I think people feel like they might say something that will trigger something. Mental health is not talked about in schools as well. I think that's coming or making a change in that area, but people don't know what to say as well. I think is another big thing, and that's why it sometimes gets smaller. But also, it might feel as though you who are experiencing the mental health difficulties, actually you thought differently about yourself and actually who you want to be around you. Now that you've gone through that quite severe process, especially if you've been in a hospital. You kind of think, actually, I don't want these kind of meaningless relationships anymore. I want to add value to my life because I see how precious my mental health is to me. So perhaps a combination.
Yeah, it's a really good point. When after I'd like suffered lots of grief and I had insomnia for years and had like the mental health effects of that, my immediate, I mean, I've got really luckily, really solid group of friends, and there are lots of people I don't speak to anymore, not because I don't particularly like them, but I think it just rejigged my value system slightly.
Yeah.
That stuff, and also spend so many years not sleeping a wink as well, and the effects of that, it really just made me rejig. When I recalibrated, I was like, yeah, I'm not really sure I value those relationships in the same way anymore. I look at them completely differently. And so you mentioned, Yvette, about education, so I'm going to go over to Lucy as the person who is most recently in education. Do you think it comes back to education, and when you were at school, was mental health talked about at all?
I think education is incredibly important when it comes to speaking about mental health illnesses and struggles. When I was at school, no, it was not spoken about. I remember very distinctly when I was in, I think, year 11, I was doing GCSE biology, and Mrs. Drury was speaking about eating disorders, but really briefly, like nothing about the psychological effects of it. It was literally just like a tiny little chapter on this one A4 page. And she said, but I can't imagine how anyone could ever make themselves sick. It's so disgusting, isn't it? And then just moved on. And I was sitting there like, okay, cool. But again, I think that just comes down to her own stigmas, you know, that she's had. She hasn't been educated. A lot of my education has been self-taught. I wanted to understand myself, but I also wanted to be able to understand other people as well, because I don't really understand people very much, but probably because of the BPD. I don't understand the way people work, really. It's very confusing to me. So learning about my own illness is really useful when it comes to my own recovery, but also just being a more empathetic and kind person. And I think, like Ian was saying, when you've gone through something yourself, you're much more likely to be able to understand someone, that even if it's a totally different illness. You know, I've never had a psychotic break, or a psychotic episode rather, but I do dissociate, which is kind of like a very kind of like microcosmic, I suppose, feeling. It's not a total detachment from reality. It's really hard to describe. It's almost like being in the Truman Show, and you just don't really feel like your life is real, and you're not really real. And that comes with a whole mess of other things that come with that, because you think, well, nothing I do really matters. So then you start engaging in a lot of harmful behaviors, whether it's like spending loads of money, or gambling, or taking drugs, or drinking. You know, people do all self-harm, people do all kinds of things. I also have a friend who also has BPD, but she would go through actual psychotic episodes, and she would self-harm in order to feel real, to like bring herself back to reality. And although I've never experienced that makes total sense to me, because I know how it feels to think none of this is really real. You and I are talking, but it's not a real conversation. We're not real. And you try and describe that to someone that's never experienced psychosis or dissociation. They're like, what are you, have you taken something? Are you crazy? Like, what's going on? And I think it's so bizarre that we're not teaching people about illnesses that affect huge portions of the population. You know, it's particularly about BPD. People think that's a really rare illness. It's not. It's 1 in 50 people have borderline. That's really common, in my opinion. I think that's a lot of people. It's between like 2 and 6%, I think it comes down to. And it's just nonsensical that we're not teaching children about human experiences, you know. But there's loads of issues with the education system. But I think speaking more frankly and openly about mental illness, the effects of it, how it can come about, talking about biological factors. You know, when it comes to BPD, lots of people think that you can only have it if you've gone through severe abuse as a child. Whilst that is really common, it can also just be the biological factor, because when you speak about BPD, there's actual brain differences. You know, your brain is producing cortisol way more than a neurotypical person. So you're constantly in fight or flight mode. And when people talk about the abandonment issues, that's kind of what's going on. In my understanding, it's that tiny triggers that for other people don't mean anything. You know, I always use the example of like a friend not messaging you back. For most people, they will go, oh, they're busy, they might be working, they're watching a film, they're taking a nap. I can go into an entire tailspin and have to reevaluate the entire relationship and think, what have I done? Do they hate me? They do hate me. You're worthless. No one will ever love you. And then quickly you're in that sunken place. And it's like this constant task of bringing yourself out of that, but multiple times a day. And if people have no education of the way that these kind of illnesses can affect people, how can they ever really have a meaningful relationship? How can they be friends with people that have these illnesses? When we speak about support systems, I've had total breakdowns in like family members and friendship relationships and romantic relationships in particular, because there's just no understanding. You know, I tried to explain, I didn't know this is before I was diagnosed. I didn't know I was experiencing dissociation. And this is my first boyfriend. I think I was 17 or 18. And I kept telling him like, but this isn't really happening. Like, do you know what I mean? And I kept saying this and he was like, no, I've got no idea what you're talking about. You're crazy. And so I just stopped talking about it, never spoke about it again. And I had OCD when I was really young. And I remember sitting in the car with my mum and I was like, Mum, I can't concentrate on what you're saying because I have to count all the letters in the words that you're saying because otherwise the car's going to crash. And she was just like, just a phase, don't worry. It's, you know, nothing to worry about. But again, that just comes down to people not knowing. I feel like I will be a hyper aware parent. I'll be like, right, how are you feeling today? Are we motivated? No, right, we're going to meditate. We've all got to meditate, figure out what's going on. Everyone's got to be happy. So I think, like Ian said, unless you've gone through something similar or have a, you know, a close relative or friends that have gone through something similar, it's really difficult to understand what the hell's going on. So of course, it's really, really paramount that we are teaching children about the effects, the dangers, the root causes, and medication and treatment, ways to deal with it.
I suppose just normalizing it. And I think that, sorry, go for it, Yvette.
Sorry, I was just going to add everything. Yeah, I agree with everything that you said, and I think that's so important. And also, emotional intelligence is really important, and a way of describing how they're feeling is so important, because I think many of us were raised by parents who didn't want to show us when we were sad or when they were crying or used to hide it, and therefore we don't know what to do when we're upset. We think, oh my gosh, this is abnormal, I need to shut it off. And it's so important that we're modeling it to our children, our nieces, our nephews, our cousins, and then we're also giving them a language for their emotions, which is something that I probably do a lot with my kids as well. So expressing how you feel when you feel angry, let's think about that a bit deeper. I've got a little boy as well, and I'm so keen not to say boys don't cry, because I think that is so unhelpful. So those kind of connotations, or if you're a girl, why are you crying? You need to be strong. Girls are strong. We can be strong and cry and have tears in our eyes. But yeah, that was my 2 pence.
That was literally, as you were speaking, I was literally about to bring up the whole crying thing. You know, even when a baby's crying, you go, don't cry, shh.
Yeah.
Why? It's a human emotion. If a baby's crying, it's because it needs something. It either needs food, affection, it's tired. That's exactly the same when you're an adult. Why are you crying? Not don't cry. Let's talk about why you're crying, and then let's figure out. And yeah, totally agree.
I mean, I think to feel like teariness, right, is a it's a natural expression of connection with other things. I mean, it's like, you know, for me, you know, I love dance, right? Strictly Come Dancing will make me be in floods most of the evening, you know. So, you know, because there's something about it that, you know, there's an emotion that's carried in it. You know, all those kind of things, you know. So, you know, if there's an emotion, I can connect with that. I'm a kinesthetic person. You know what I mean? I'm going to feel it, right? And so if I feel something like that, it's going to make me feel emotional. And I enjoy feeling emotional. I think it's fine.
Yeah.
You know, I don't have a problem with it whatsoever. I think it's important to let those things out.
Well, it's why we connect to music and art and things like that. That's all of those things are things that, you know, that evoke feeling. And yeah, expressing that feeling, there's nothing wrong with. And actually, kind of on that vein, there's different, you know, I mentioned earlier about the way that different disorders and how mental health is depicted on TV and in film. And there certainly are positives. Like, for example, Jacqueline Wilson, who has been doing the Lord's work for ages, in her books, and the way she describes everything, illustrated mum, literally, if the world was burning, we need to save that book. So, and her books, the way she talks about and normalizes divorce and mental health issues and just things that people are going through, and kids can read it and connect with it and start to understand the world and themselves. And even up to now, The Babysitter's Club on Netflix, I loved it, watched it in one day. But the reason why I liked it so much is because it was very much about just connecting children to the real things that the adults in their lives are going through and themselves, and explaining it so that the young audience would also learn and connect with it, because they touch on touch on mental health and self-care, and literally even like somebody having diabetes. They touch on young people in trans issues and everything, just in this way which that's just completely, it doesn't feel like it's forced or anything. But do you think that, I'm going to go to Yvette with this one, do you think something needs to be done or about the way that TV and film do depict these things?
Yes, I completely agree. And I would add also the way that stores market things, because we're coming up to Halloween, and that annoying costume, that psycho costume that was at Tesco or Asda were selling is horrible. Completely, like, it should be banned. It should be against the law to even use that word. And I think TV and film do contribute to it negatively, because they only show one side of it. They don't show how complex mental health is. I think some programs are coming a long way with that, but just showing that complexity about mental health, showing how much it can affect the things that are important to that person, showing that curiosity about what the person is experiencing and why. And that's something that I love about working with people experiencing psychosis, is making meaning of what their hallucinations are, because they have meaning. I think it's blocked by TV and so forth. And also thinking about how particular mental health difficulties are attached to certain genders. So we know that women are more likely to be diagnosed with depression, but yet men are more likely to attempt to take their life. So that means that's an influence of how media portrays women crying, and that means you're depressed. And if a man doesn't cry, oh, he can't be depressed, he's just angry. So all of that influences then how mental health services respond to people and how society as a whole responds to it. So I completely agree with that.
Brilliant. Okay, so we're going to start to wrap up, but I just wanted to go over a few other kind of misconceptions around it, just because we had some additional questions in, and things around like, can you have a mental health disorder and date? What is the relationship between having mental health disorders and going to therapy, and religion and working? So I think we're going to touch on those three before we wrap up. So I'm going to go to religion first with Yvette. So what is, I don't know, is there kind of some kind of intersectional clash or anything with those things?
So this is an area I'm really passionate about, because I'm also a Christian. I believe that faith, whether it's religion, spirituality, just being a part of community, can play a really important role in your recovery. In terms of prayer, so research has shown that actually prayer has a meditative effect that's been shown in the brain. As a Christian, we do something called talking in tongues, which sounds very much like Babel. But again, like brain studies have shown that when people talk in tongues, the frontal lobe, which is the planning, the kind of organizational bit, goes offline. And the person is able to kind of re-engage that relaxation part of their brain. So research has shown how important faith is in recovery. But I think the difficulties arise whereby people think, if I seek help for mental health treatment, that means that I doubt, the power of my faith and God healing me effectively. And again, I would say there's no way that you would your leg would be broken, and you'll kind of sit down and say, okay, I'm going to wait for God to kind of heal me. Actually, you'll do something about it whilst even activating your faith. There's no reason why the two cannot operate together. You know, pray for your doctors if you want to, meditate on their behalf, and hope that God will guide them to use the right therapy for you, or that they will treat you fairly. So there's no reason why they can't be separate. And also, like my trust, we have values which very much align with my faith in terms of compassion and respect. I feel like the NHS as a whole is part of compassion and being there for people who are struggling at the moment. So I think, yeah, those are some of why people feel like it can't connect as well, and why it can effectively. And also, sorry, just to add, I know that in some faiths there is beliefs about mental health being caused by demons, by witches, by curses, and that again I think leads people maybe to seek more of support from their churches or their mosques or from spiritual. And actually it's thinking about that kind of complexity of mental health. Yes, still pray, but also what can we offer you as a service? And if we can't offer you something, then that's okay. We just want to keep encouraging you on that recovery too.
Brilliant, thank you. And I'll go to Ian. So work, gaining employment, so going back to work, etc. Can you come through a psychotic episode and then still work and go back to work and fulfill your job?
Yeah. I mean, yeah, absolutely, 100%. Yeah. I mean, I kind of, you know, in social work education, I get a little bit disappointed sometimes in some of the people that get wheeled out as experts by experience. Not because they shouldn't, they absolutely should, but because I always wheel out somebody who hasn't quite got into work, or hasn't quite got out of the benefit system, or hasn't quite got a roof over their head, you know, or hasn't quite, you know, done certain things. Like there's, you know, mental health is an inhibiting factor to you being successful in your employment. You know, it's not, you know, I guess I remember returning to work, and returning to work is challenging, but I made a clear decision that I was going to let everybody in my department know where I'd been and why, right? So that I didn't have to walk back into my department with my head sort of down and people looking, oh, I wonder where he's been. And we've been doing all his work while he's been off, and looking, you know, what's that all about? Right? I didn't want that. I wanted people, you know, gave people the opportunity to, if they want to ask me questions about my experience, they could do. If they wanted to, if they noticed something about me and they wanted to share that with my bosses, then they could do. You know, only one person ever has, and they got it wrong, right? But at least they did.
Yeah.
Right? And, you know, I guess it's all about preparation, right? You know, I was supported back into work. So, you know, I got 4 months after I was detained, I emailed my boss and said, can you make an Occi Health referral for me, right? So I can go and see the occupational health doctor, right? And then I emailed him straight back the next day and said, no, forget that, it's too early, right? Because it just felt too uncomfortable. And then a month later, I said, right, okay, now do that. And then I went to see the occupational health doctor, and he signed me off for another month, you know. And then you have the whole return to work cycle where you're sort of sitting in a meeting with HR and your boss, and you're talking about your sickness absence and your ill health and all of that kind of stuff. And, you know, having conversations about their concerns about whether you're going to be able to manage what is a stressful job. And, you know, and all I can say is, well, you know, if I'm not, I'm going to let you know, because my health's more important than my job, you know. And I guess then you kind of get into management strategies of how I'm going to manage my day to day. So I had a phased return to work, but also started to manage my head by, I told people, if I put my earphones in, just leave me alone.
Yeah.
Right? And then if I put my earphones in and I walk away, definitely leave me alone. Right? And then, you know, you have occasional disappearances off to have to the toilets to have like a mini meltdown, and then you can come back. But you kind of work out your little strategies at work, and that also includes, you know, having cooperatives with people. you know, and you know, it was unfortunate that my boss at the time was amazing and amazingly supportive, and is a brilliant guy, and I'm forever in his debt, right, for his support of me getting back into work. Now, the person that replaced him, unfortunately, wasn't there, and was a major contributor to the fact of me breaking down in the first place. Yeah. So then to be working with that person after that, unfortunately, I've kind of changed departments now, so it's kind of suitable. But in terms of getting back to work, I would have said the way my brain works has massive benefits to the organisation.
Yeah.
As you know, and it's really difficult for me to see that, right, and for me to believe that I do a good job on a daily basis. But that's how my challenges of my childhood and into adulthood affect me.
Yeah.
And how I arrived at being in hospital in the first place. All that doubt and question and paranoia. Yeah, I mean, that doesn't go away, but I can still work.
Yeah.
In some ways, it feeds my...
Oh, I've lost you there for a sec. I lost you there for a sec, Ian. I only missed the end of it, just the last.
Yeah, I was just going to say, you know, the experience allows me to work quite effectively with other human beings and my team. Yeah, managing a team is a good place to have lots of good empathy.
Yeah, and Yvette, I saw you put your hand up there.
Yeah, because I just wanted to add that it's actually against the law to discriminate against someone who's experiencing mental health difficulties. So in the same way that Ian, like, I'm so glad to hear that you had such a good experience of returning to work and them adjusting. And part of the Equality Act 2010, hopefully they're going to do like a revised one for 2020, is that you can't discriminate against someone who has experienced it. And also, like, within my service, and Ian, I don't know whether you accessed it, we have employment specialist workers, and they will support you through meetings at work as well, so that you're, you know, whether you want your boss to give you a couple more breaks in the day, if that's around when you have triggers and so forth. There's so much support in terms of getting you back to work that is available and important to access too. So just, again, adding my 2 pence, sorry.
I mean, for me, I had amazing support from the Social Workers Union, because I'm like a British Association of Social Workers member. And you know, just as a little anecdote, right? When it came to thinking about returning to work, and this is before I'd kind of spoken to my boss or anybody, you know, you're kind of thinking, well, I put a lot of effort into my qualifications. I put a lot of effort into my career. Now I've lost it all. Why would my local authority want to employ me? Why would they want me back? You know, I'm useless. I'm hopeless, and my career's over. Yeah, and then I spoke to the Social Workers Union, and I mean, working with somebody on the telephone is an art form, right? And this person on the end of the telephone didn't really say anything to me. They just facilitated me to open my soul, right? And all they said really was, yes, I see. And that's all they said all through 45-minute conversation. Well, I say conversation, it was me. Right? And then they navigated me to arrive at my own conclusion. It was genius, right? And I had to email and tell them how genius it was, right? Because I know how difficult that is to do, to stop yourself saying stuff, right? To offer advice. You know, she just allowed me to arrive at the right answer for myself. It was amazing. So that, you know, the union for me, the Social Workers Union specifically, was brilliant.
Yeah, brilliant. Okay, and then so the last one to Lucy, just like dating, relationships, etc. And it's like, okay, so we're both gonna laugh about this because we make a few jokes about this in our own lives, don't we, Lucy? But just generally, dating with dating with a mental health disorder, like.
So I think in general, it's really difficult. But it's really difficult for the majority of people actually to communicate correctly and trust people and not have preconceived ideas about you know, how a relationship might end or how it might go and things like this. So my personal struggle with it is whenever something happens, I always go, oh, it's because I'm BPD. And then that spiral starts again. And the bottom layer is you are unlovable. You don't have any value. So once that spiral goes down, it's really difficult to then actually have any healthy boundaries within a relationship, because I will pretty much put up with anything just so you don't leave, because I have chronic abandonment issues. So I think borderline is a really, really difficult illness to have when it comes to dating. Also because of the misconceptions about people with BPD, you know, we're even in films and stuff, we're told that we are manipulative, we're dangerous, we're not capable of love, but pretty much the opposite of those things. I do think that people with BPD have the ability to be manipulative, but it's never on purpose, in the way that if you speak about someone someone that is diagnosed as a psychopath, that's actually actively trying to manipulate people to feed your own ego or to benefit you. When it comes to people with BPD, it's manipulation in the way of trying to not lose someone the majority of the time. And although you can go about that in very harmful ways a lot of the time, it's coming from a place of pain, it's coming from trauma, it's coming from the need to be loved. So, you know, I think dating someone with BPD, you have to be very empathetic, you have to be able to listen, you have to be able to validate someone. And I haven't found anybody like that, because I do think it's hard work, and that's fair enough. I think once I'm at a stage where I am further along in my recovery and hopefully don't meet, you know, necessarily all of the diagnostic criteria anymore, then dating would be a lot more simple for me. But for now, it's a whole mess, to be honest, because it's so difficult to not spiral and to not always think this person definitely will hate me, they will hurt me, they will cheat on me, they will mistreat me, they will abuse me, because all of my life experiences have given me evidence that they will. And BPD, you're constantly living in the past, always. You're never ever really in the present moment, unless you're, you know, actually firm in your recovery and you're meditating and you're doing grounding exercises and things like this. You're constantly living in fear, and fear comes from past trauma, always, you know, unless it's like instinctual fear, but that's a whole other kettle of fish, because your instincts are wrong as well because of the cortisol production. So the whole thing is really difficult, to be honest.
It's really not impossible.
Yes, I wish I could, you know, be like an example and be like, yeah, I'm happily married, like I'm great, I'm so loved, but unfortunately I don't have that story yet, but I have faith.
Yeah, but also as well, age as well, you're still quite young, so you know, when I was your age, I was single and making wild decisions. So, you know, I think that's an age thing that can happen as well. Not that I haven't stopped making wild decisions, but anyway. So I'm going to leave the last word with Yvette, and I'm going to say to Yvette, what would you say to someone who is struggling to come to terms with their mental health issue?
Yeah. Oh, I would have thrown that to Ian and Lucy as well. But I guess from my perspective, that it's knowing that there's a way out. It might not look like tomorrow things go back to normal, but over time, on the road to recovery and on that journey, you'll learn strategies. You will come to terms with the experiences through talking, maybe through medication, through engaging with your values, but there's definitely a way out. And most importantly, you having mental health difficulties does not change you as a person. You're caring, you're still loving, you're still amazing, you're still funny. People still want to be around you. That doesn't stop your personality in any way. And there's support available. So that was more than one thing. I'm sorry. So,
no, that's fine. That's perfect. I just want to say thank you so much. I know that, Yvette said at the beginning that, you know, this could have been a tricky one to sit through. So is there anything that you wanted to kind of end with, Yvette, just kind of to wrap that up, and how anyone might feel after having watched this?
Yes. I know we thought about doing maybe progressive relaxation. Is there still a bit of time?
I don't know, we're kind of losing our audience slightly just because we're getting kind of towards the end. But I suppose we'll wind down, and when people want to leave, they can. So we can still kind of do that. That'd be great.
Okay. So we're going to just do like a quick progressive muscle relaxation task, and it's something that I really like doing because we hold a lot of anxiety and stress in our body, and it's really important that we kind of allow our bodies to relax, because that affects how we think, how we feel, most importantly our sleep. We're heading to bedtime in a bit for some of us, so I'm going to kind of talk you through it, and hopefully you'll find my voice relaxing as I read the relaxation script. So if you're able to kind of get into a comfortable position.
I'm gonna take a nap.
Yeah. If you want to, yeah, progressive.
Putting my feet up under my desk. Okay.
Yeah, sounds good. Okay. So begin by taking a deep breath and noticing the feeling of air filling your lungs. Hold your breath for a few seconds. Release the breath slowly and let the tension leave your body. Take in another breath and hold it. Again, slowly release the air. Even slower now, take another breath. Fill your lungs and hold the air. Slowly release the breath and imagine the feeling of tension leaving your body. Now move your attention to your feet. Begin to tense your feet by curling your toes and the arch of your foot. Hold on to the tension and notice what it feels like. Now release the tension in your foot and notice the feeling of relaxation. Next, begin to focus on your lower leg. Tense the muscles in your calves. Hold them tightly and pay attention to the feeling of tension. Now release the tension from your lower legs. Again, notice the feelings of relaxation. Remember to continue taking deep breaths. Next, notice the muscles in your upper leg and pelvis. You can do this by tightly squeezing your thighs together. Make sure you feel tenseness without going to the point of strain. And release. Feel the tension leave your muscles. Begin to tense your stomach and your chest, and you can do this by sucking your stomach in. Squeeze harder and hold the tension a little bit longer. Now release the tension. Allow your body to go limp. Let yourself notice the feeling of relaxation. Continue taking deep breaths. Breathe in slowly, noticing the air fill your lungs, and hold it. Release the air slowly. Feel it leaving your lungs. Now tense the muscles in your back by bringing your shoulders together behind you. Hold them tense and tightly together without straining, and keep holding. Now release the tension from your back. Feel the tension slowly leave your body and the new feeling of relaxation. Notice how different your body feels when you allow it to relax. Tense your arms all the way from your hands to your shoulders. Make a fist and squeeze all the way up your arm and hold it. Now release the tension from your arms and your shoulders. Notice the feelings of relaxation in your fingers, your arms, your hands, and your shoulders. Notice your body feeling limp and at ease. Finally, tense your entire body. Tense your feet, your legs, your stomach, your chest, your arms, your head, and your neck. Tense harder without straining, and hold the tension. Now release. Allow your whole body to go limp. Pay attention to the feeling of relaxation and how different it feels from the feeling of tension. Begin to wake your body up slowly by moving around your muscles. Adjust your arms and your legs. Stretch your muscles and open your arms when you feel ready to. And welcome back to the room. And thank you for the 9 who stayed with us as well.
Thank you so much. Brilliant. Okay, thank you so much, guys. Thank you for joining me. Thank you for joining us today. And please check our Instagram for sessions that are coming up over the coming weeks. They're all themed around different topics relevant to stress, personal development, career, finance, especially during this tricky year, job loss, children's mental health, family, and men's mental health as well. Anyway, thank you so much, everyone. Bye.
Thank you.
Bye.